welcome to the deep dive. If you're studying for the OBGYN NBME shelf, well, you've come to the right place. We're really going to try and cut straight to the high-yield stuff you absolutely need.
Exactly. We've been digging into First Aid for the OBGYN clerkship, the 5th edition, focusing specifically on contraception, menstruation, PMS and PMDD, infertility, amenorrhea, and hyperandrogenism.
Right.
Our mission really is to pull out those critical, frequently tested concepts, help you connect the dots, understand why this stuff is important, not just for the test, but for actual practice.
Okay, let's dive right into contraception then. There are, so many options out there. It can feel a bit much.
It can.
The book breaks it down pretty well, though. Barrier methods, hormonal agents, IUDs, emergency contraception, sterilization, and fertility awareness methods. So thinking about barrier methods first, like condoms, what are the absolute key points there?
Well, the big one really is STI protection. Male and female condoms are the only ones that do that. Yeah. And male condoms, efficacy is pretty decent, 86 to 97%. But that higher number really hinges on, perfect use, consistent and correct.
Real world versus perfect use, always a gap there.
Always. Female condoms are, less common, maybe a bit less effective overall.
Okay. Then you've got diaphragms, cervical caps, these need fitting, right? And spermicide.
That's right. Fitted by a provider, used with spermicide. The diaphragm has to stay in for 6-8 hours afterwards. There's a small risk of UTIs and very rarely TSS.
And the cervical cap, its effectiveness changes if you've had a baby before.
Yeah, it's less effective in Paris women, around 80-90% for nulliparous, but drops to maybe 60-70% for Paris women. Then you have spermicides alone, or the sponge, often best used with another barrier to boost things.
Got it. Okay, hormonal methods. This is a huge area for the shelf, I imagine.
Definitely. Combined oral contraceptives, COCs, are, incredibly effective if taken properly, like 92 up to 99.9% effective with perfect use.
And how do they work? It's not just one thing, is it?
No, it's multi-pronged. They suppress FSH and LH, which stops ovulation. They thicken cervical mucus, making it harder for sperm to get through. And they thin the uterine lining, making implantation less likely.
And beyond just preventing pregnancy, there are other benefits too.
Absolutely. A big one is reducing the risk for ovarian and endometrial cancers, probably tied to fewer ovulation cycles over a lifetime, plus regulating periods, helping with acne sometimes.
But they're not suitable for everyone. The contraindications are really key to know.
Super important. The book gives that example, right? The 37-year-old patient, age over 35, and smoking is a major red flag for blood clots, even heart attack risk.
Yeah.
Other big ones are a personal history of VTE, like DVT or PE, uncontrolled high blood pressure, certain thrombophilias, migraines with aura. It's a list you really need to know. Safety first.
Definitely. So what about progestin-only options? The mini pill.
Good alternative, especially for women who are breastfeeding or can't take estrogen for whatever reason. The main mechanism there is thickening the cervical mucus.
But the timing is critical.
Very critical. Needs to be taken at pretty much the exact same time each day. Less forgiving than COCs. Then you have the patch and the ring. They deliver both estrogen and progestin. Similar effectiveness to COCs.
Easier compliance for some people, maybe?
Potentially, yeah. Weekly patch or monthly ring instead of daily pill. But the patch might be less effective in women with higher BMIs, and there's maybe a slightly higher VTE risk with the patch compared to pills, though data is debated.
Okay. What about injectables, like Depo-Provera?
Right, DMPA. That's a progestin-only shot every 3 months. Very effective, like 99.7%. Works mainly by blocking the LH surge needed for ovulation.
And the vignette mentions it might be good for someone with epilepsy.
Yes, progestin-only methods like Depo or even implants can sometimes be beneficial for women with seizure disorders or even sickle cell disease. Fewer hormonal fluctuations, maybe?
But side effects? Irregular bleeding is common, I hear.
That's the main one, especially initially. Also, potential weight gain and a temporary decrease in bone density, which is generally reversible after stopping.
And implants?
Yeah.
Like Nexplanon?
Yeah, the etonogestral implant. Tiny rod under the skin in the arm, lasts for 3 years. Again, progestin only, super effective, over 99% effective. Works similarly, suppresses ovulation, thickens mucus.
Good for those who can't use estrogen or want something long-acting.
Exactly. Main side effect, again, is unpredictable bleeding patterns, sometimes acne, weight gain, headaches. And removal can occasionally be a bit tricky.
Okay, let's move to IUDs, intrauterine devices. Two main players here.
Yep. The levonorgestrel IUD, think Mirena, Kylena, etc., releases progestin locally in the uterus, thickens mucus, thins the lining, lasts about 5 years, depending on the specific device. Bonus, it often reduces menstrual bleeding, can even treat heavy periods.
And the other type?
The copper IUD, Paragar, is the main one. It's hormone-free, works by creating an inflammatory reaction that's toxic to sperm and ova, lasts for 10 years. Great option for women who want long-acting contraception but can't or don't like hormones.
Both highly effective, right?
Very effective, yeah. Up there with sterilization and implants. Over 99% effective.
But contraindications. When should you avoid placing an IUD?
Definitely avoid if there's a current STI or pelvic inflammatory disease, PID, or within the last 3 months for the copper one. Also, unexplained abnormal uterine bleeding needs investigation first. Uterine or cervical cancer, current breast cancer for the hormonal IUD. And a significantly distorted uterine cavity can make placement difficult or impossible.
And complications, though, rare.
Rare but important. Risk of infection, like endometritis or PID, mostly around the time of insertion. That vignette with the postpartum patient highlights this. Uterine perforation during insertion, though uncommon. Expulsion of the IUD. And if pregnancy does occur, which is rare, there's a higher chance it's an ectopic pregnancy.
Okay. What if someone needs emergency contraception?
Several options. Need to act fast. Within 5 days is the window for most. Levonorgestrel pills like Plan B one-step are available over the counter for some. They mainly work by delaying or inhibiting ovulation.
But not the most effective option.
Actually, no. The most effective emergency contraception is placing a copper IUD within that 5-day window. A levonorgestrel IUD can also be used off-label. Then there's ulipristal acetate, prescription only, it's an antiprogestin, also works up to 5 days by delaying ovulation and possibly impairing implantation.
That 19-year-old vignette is a classic case for needing EC.
Exactly.
All right, last category here. Sterilization. Permanent options.
Right. For men, vasectomy. Cutting or sealing the visi deferens. Simple procedure, very effective, but need follow-up sperm counts to confirm sterility. Usually takes about 12 weeks or 20 ejaculations.
And for women?
Tubal occlusion or removal. Can be done postpartum or as an interval procedure. Traditionally, methods involve blocking the tubes, clips, bands, cautery, but increasingly the standard is becoming bilateral salpingectomy.
Removing the tubes entirely.
Exactly. Not only is it highly effective contraception, but it also significantly reduces the risk of ovarian cancer later in life, as many ovarian cancers seem to originate in the fallopian tubes.
That's a huge benefit.
It really is. Important counseling point, though. All sterilization should be considered permanent. Reversal is complex and often unsuccessful.
Okay, great overview of contraception. Let's shift gears now to menstruation. Talk about puberty first.
Sure. Puberty is that whole transition to sexual maturity. It kicks off when the brain, specifically the hypothalamus, starts releasing more GnRH, gonadotropin-releasing hormone.
Which triggers?
Triggers the pituitary to release FSH and LH, follicle-stimulating hormone and luteinizing hormone. These act on the ovaries, stimulating estrogen production.
And the estrogen causes the physical changes.
Right. Breast development, the B-large, growth spurts, changes in the uterine lining, the endometrium. Then, usually after breast development, you get pubic hair growth pubarch, which is driven more by adrenal androgens. And finally, menarche, the first menstrual period.
The sequence is usually the large, then pubarch, then menarche.
Typically, yes. And the Tanner stages are just a standardized way to track these changes from pre-puberty to adult development.
What about when puberty happens too early? Precocious puberty.
That's defined as starting before age 8 in girls. Needs evaluation. Can be central, meaning the brain's hormonal axis activates early, often idiopathic, no clear cause found. Or peripheral, meaning hormones are coming from somewhere else, like an ovarian cyst or tumor, or even external exposure.
Okay. Now, the menstrual cycle itself, the average 28 days.
Right, average is 28, but normal is anywhere from 21 to 35 days. First half is the follicular phase, day 1 to about day 14. FSH stimulates ovarian follicles to grow, one becomes dominant, and it produces increasing amounts of estrogen.
And the estrogen builds up the uterine lining.
Exactly, proliferative endometrium. Then, around mid-cycle, day 14 usually, that high estrogen triggers a big surge of LH.
The LH surge, that's the key for ovulation.
That's the trigger. Releases the egg. The follicle that released the egg then transforms into the corpus luteum,
which starts the second half.
The luteal phase, days 14 to 28. The corpus luteum pumps out progesterone, mostly. This matures the uterine lining, makes it secretory, ready for potential pregnancy.
And if no pregnancy happens?
The corpus luteum degrades after about 10-14 days. Progesterone and estrogen levels plummet. That withdrawal of hormones causes the uterine lining to break down and shed, and that's menstruation. Average period lasts about 5 days.
Makes sense. Now, related to the cycle, let's talk PMS and PMDD, premenstrual syndrome and premenstrual dysphoric disorder.
Right. Important distinction here. These symptoms specifically occur in the luteal phase, the second half of the cycle, and importantly, they resolve shortly after the period starts. That timing is key to differentiate them from, say, underlying depression or anxiety, which would be more constant.
And PMDD is the more severe form.
Much more severe, causes significant distress, interferes with work, school, relationships. PMS involves behavioral or physical symptoms that cause some impairment. The 26-year-old vignette kind of illustrates typical PMS symptoms.
So for PMS diagnosis, you need symptoms in the luteal phase causing issues, resolving with menses, documented for like 3 cycles.
Exactly. Perspective charting is really helpful. Need at least one mood or physical symptom like irritability, bloating, fatigue, breast tenderness, and rule out other things.
And PMDD criteria are stricter from the DSMV.
Yes. Requires at least 5 symptoms total, with at least one being a significant mood symptom like marked depression, anxiety, mood swings, or irritability. Again, timing is crucial, luteal phase only, causing significant impairment. The 17-year-old missing school is a good example of that level of severity.
How do you treat these?
Depends on severity. Mild PMS might respond to lifestyle things, exercise, stress reduction, maybe vitamin E for breast pain.
Okay.
For more severe PMS and definitely for PMDD, SSRIs are often first line, can be taken continuously just during the luteal phase or even just starting when symptoms begin. Certain oral contraceptives, especially continuous ones or those with a short placebo interval, can also be very effective.
What about really severe refractory cases?
Then you might consider GnRH agonists to suppress the cycle completely, but that induces menopause-like side effects. Rarely, as a last resort, surgery like removing the ovaries might be considered, but that's extreme. Cognitive behavioral therapy can also be helpful.
Okay, let's move into infertility. How is that defined?
Generally, it's the inability to conceive after 12 months of regular, unprotected intercourse if the woman is under 35, or after just 6 months if she's 35 or older. It affects about 15% of couples, so it's pretty common.
And the causes can be male factor, female factor, or both.
Or unexplained, yeah. Workup always involves both partners. For the male partner, the first step is usually a semen analysis, checking sperm count, motility, shape.
Needs to be done carefully, right? Abstinence beforehand.
Right. Typically 2 to 5 days of abstinence, and often repeated 1 to 2 weeks later since results can vary. It gives a snapshot of sperm production over the previous 3 months.
And for the female partner, where do you start?
First, assess ovulation. Is she ovulating regularly? History of regular cycles is a good sign. Can check a mid-luteal progesterone level day 21 in a 28-day cycle. Should be above 3 ng/ml if ovulation occurred. Or use LH predictor kits.
What if she's not ovulating regularly, like the 28-year-old vignette with irregular periods?
And you need to figure out why. Could be hypothalamic issues, pituitary problems like hyperlactin, thyroid dysfunction, or very commonly PCOS, polycystic ovary syndrome, which often presents with irregular cycles and signs of hyperandrogenism.
And assessing ovarian reserve, how many eggs are left, essentially.
Yeah, evaluating the egg supply. Day 3 FSH level, AMH, anti-Mullerian hormone, antral follicle count on ultrasound. These give an idea of remaining ovarian function, especially important in older women or if primary ovarian insufficiency is suspected.
Okay, beyond ovulation, you need to check the anatomy. Uterus and tubes.
Absolutely. A hysterosalpingogram, or HSG, is often the first test. It's an X-ray with dye to see if the fallopian tubes are open and check the shape of the uterine cavity.
What if the HSG shows something abnormal in the uterus?
Then you might proceed to hysteroscopy, putting a camera directly inside the uterus. It's diagnostic and therapeutic. You can remove polyps, fibroids, adhesions like in Asherman syndrome, or resect a uterine septum. The 30-year-old vignette needing uterine evaluation fits here.
And tubal problems, like from past infections.
Yes, past PID, like in that other 30-year-old vignette, is a major cause of tubal scarring and blockage. HSG checks patency. Laparoscopy with chromotubation injecting dye during surgery is another way. If tubes are blocked or damaged, IVF is often the most effective treatment.
And sometimes the issue is outside the uterus and tubes, like endometriosis.
Right, peritoneal factors. Endometriosis or adhesions from prior surgery can impair fertility. Laparoscopy is the gold standard for diagnosis and treatment here, removing endometriosis lesions, leasing adhesions.
When these specific issues can't be fished, or if it's unexplained, that's where RD comes in. Assisted reproductive technologies.
Exactly. Things like IUI, intrauterine insemination, placing washed sperm directly into the uterus around ovulation time, requires patent tubes, or IVF, in vitro fertilization, taking eggs out, fertilizing them with sperm in the lab, and transferring the resulting embryo back into the uterus.
And ICSI.
Intracytoplasmic sperm injection. That's used with IVF, usually for severe male factor infertility. A single sperm is injected directly into each egg.
Okay, comprehensive look at infertility. Now, amenorrhea, absence of periods.
Right. Two types. Primary and secondary. Primary is never having had a period either by 15 with normal growth and secondary sexual characteristics, or by 13 without any signs of puberty starting.
And secondary.
That's when someone used to have periods, but they've stopped. For more than 3 months if cycles were regular, or more than 6 months if they were irregular.
First thing to rule out in secondary amenorrhea.
Always pregnancy. Even if they say they're using contraception, like the 30-year-old on OCPs who stopped bleeding first step is a pregnancy test.
Okay. For primary amenorrhea, the evaluation depends on physical findings.
Yeah, specifically presence or absence of breasts, indicating estrogen exposure, and presence or absence of a uterus, checked by ultrasound usually.
So like no breasts, but uterus present.
Suggests lack of estrogen from the ovaries. Could be gonadal dysgenesis, like Turner syndrome, 45X, or hypothalamic pituitary failure to produce FSHLH.
Breasts present, but no uterus.
Classic examples are Mullerian agenesis, MRKH syndrome, where the uterus and upper vagina don't develop, but ovaries are normal, or complete androgen insensitivity syndrome, CAIS. That's 46XY, genetically male, but tissues can't respond to testosterone, so they develop female external genitalia, have breasts but no uterus, and tests internally. The 18-year-old vignette with absent uterus and pubic hair sounds like CAS.
Wow, complex. And secondary amenorrhea causes.
Very broad. Can be hypothalamic stress, excessive exercise, eating disorders, weight loss. Pituitary causes tumors like prolactinomas, or damage like Sheehan syndrome after postpartum hemorrhage. Ovarian causes primary ovarian insufficiency. POI, basically early menopause, like the 35-year-old with hot flashes and high FSH. Or PCOS, again, like the other 35-year-old vignette with oligomenorrhea and hyperandrogenism. Uterine causes like Asherman syndrome, scarring inside the uterus, even thyroid problems.
So the workup involves history, exam, and labs.
Definitely. HCG first, then typically TSH, prolactin, FSH. Depending on clinical picture, maybe testosterone if signs of hyperandrogenism, maybe estrogen levels, maybe a progestin challenge test to see if they bleed after withdrawing progesterone.
Got it. Last major topic, hyperandrogenism, excess androgens.
Right. Manifests often as or hirsutism, male pattern hair growth, like chin, upper lip, chest. Can progress to virilization, clitoromegaly, deepening voice, male pattern baldness, which is more concerning, often suggests a tumor.
Where do these androgens come from?
Primarily the ovaries and the adrenal glands. Ovaries make testosterone, androstenedione. Adrenals make DHEA, DHEAS, and some androstenedione. Testosterone can also be converted to the more potent DHT in peripheral tissues like hair follicles.
Sometimes hirsutism happens even with normal hormone levels?
Yes, that's called idiopathic hirsutism. Normal testosterone, normal DHEAS, regular periods, thought to be due to increased sensitivity of the hair follicle to androgens, maybe more 5-alpha reductase activity locally, like the 35-year-old vignette with increasing hair but normal labs.
What about adrenal causes of high androgens?
Cushing's syndrome, excess cortisol, can be from an adrenal tumor, pituitary tumor, Cushing's disease, or ectopic ACTH production. Often causes hirsutism, irregular periods, along with other signs, and congenital adrenal hyperplasia, CAH. Most common is 21-hydroxylase deficiency. Enzyme block shunts precursors towards androgen production, can present at birth with ambiguous genitalia, or later in life with hirsutism acne, irregular periods, late-onset CAH.
And ovarian causes.
PCOS is the most common overall cause of hyperandrogenism. Remember the Rotterdam criteria. Need 2 out of 3 of hyperandrogenism, clinical or biochemical, oligo or anovulation, and polycystic ovaries on ultrasound. Often associated with insulin resistance, obesity. The 24-year-old obese woman with amenorrhea and facial hair is classic PCOS.
Are there ovarian tumors that make androgens?
Yes, though rare. Sertoli-Leydig cell tumors, often in younger women. Hillar cell tumors, usually postmenopausal. These typically cause rapid onset of hirsutism and virilization. That 25-year-old vignette with rapid virilization screams tumor workup.
So evaluation involves measuring specific hormones.
Right. Total testosterone and DHEAS are key first steps. High testosterone often points to ovarian source or severe adrenal source. High DHEAS specifically points to adrenal source. If those are very high or symptoms are rapid severe, you need imaging ultrasound, CT, MRI to look for tumors. Specific tests like 17-hydroxyprogesterone for CAH, dexamethasone suppression for Cushing's might be needed.
And treatment depends entirely on the cause.
Absolutely. Tumors need surgical removal. CAH might involve glucocorticoids. PCOS management focuses on lifestyle, OCCs, or cyclic progestins for endometrial protection and cycle regulation, anti-androgens like spironolactone for hirsutism, and often metformin if insulin resistance is present. Letrozole is first line for ovulation induction in PCOS if fertility is desired. Idiopathic hirsutism can be managed with OCPs, anti-androgens, and cosmetic measures like laser hair removal.
Wow, that was a lot, but definitely high yield. You can really see how interconnected everything is. The hormones, the cycle, the potential problems.
Totally. Understanding that underlying HPO axis, hypothalamic pituitary ovarian axis, and how it influences everything from periods to fertility to androgen levels is just fundamental. It's not just about memorizing facts for the shelf, it's the foundation for taking good care of patients.
Absolutely. So as you're reviewing, maybe take a moment to think about which of these areas, contraception, menstruation, PMS, infertility, amenorrhea, hyperandrogenism, felt the most challenging for you. Might be worth circling back to those sections in First Aid or your other resources.
And maybe a final thought to leave you with, considering this huge range of conditions impacting women's reproductive health, what are some of the ethical considerations that come up? In counseling about contraception, managing infertility treatments, dealing with conditions that affect body image or identity, something to ponder beyond just the pure science.